So about 5 years ago, we found that atrial fibrillation patients had a much higher risk of dementia. At that time, including dementias that previously did not really have risk factors such as Alzheimer's disease, idiopathic dementia. But at that time, we didn't understand the true mechanisms behind it. Now, we've for a long time known that atrial fibrillation results in stroke. And if you have lots of strokes, you can have dementia from that, what we call multi-infarct dementia. But we postulated at that time perhaps idiopathic dementia, Alzheimer's dementia that's characterized by brain volume loss is just a manifestation of small injuries or small clots over time that reach a burden, and all of a sudden cognition is affected. So about a year ago, we started looking at stroke prevention and dementia risk, specifically warfarin, which is the most commonly used drug to prevent stroke in atrial fibrillation patients. And in those patients, when we found they were under anticoagulated, for a period of time, there was a significantly higher risk of dementia. But at the same time, we found if they were over anticoagulated, a similar paradigm, so a U-shaped curve, so to speak, with higher risk on both ends. One of the things with atrial fibrillation is about 30% of people are also on aspirin or an antiplatelet drug because they've had a heart attack, they've had a stent, a bypass surgery. And so these patients were perhaps at higher risk of developing dementia because they had two medicines that could impact small bleeds in the brain. The goal of this research is obviously to help people live longer, to minimize heart disease, brain disease, improve quality of life in patients with atrial fibrillation, because we know it significantly impacts quality of life. And these type of studies help us to identify things that impact that decline and at the same time, hopefully improve it. So that's certainly a goal of the research.
Cool.
We took slightly over 1,000 patients that had no history of dementia and had 4 to 5 years of follow-up that were managed very carefully in our warfarin clinics. And we looked at percent time that they were over anticoagulated, whether it was less than 10%, 10 to 25, or greater than 25%. And what we found was a significant increased risk of dementia in those that were over anticoagulated. Dementia risk in that population over the follow-up time was 6% versus about 2.7% in those that had over anticoagulation times less than 10%. And when we controlled for everything, the hazard ratio was 2.59, or essentially 2.5 times more likely to develop dementia despite all other variables if you were over anticoagulated. One of the interesting things that we ask is, so we have all these things that track along with aging, and perhaps they're all a manifestation of aging. And what we found was the highest risk of having a problem were in the youngest patients that had problems with over or under anticoagulation. So we thought that really prompted us to really try to sort out what can we do. So I think there's a few things we can do. One, there's a lot of people that are on aspirin that don't need it. People take aspirin because they see a commercial and think it's heart healthy. They can stop. Patients that are treated with aspirin for a long time that don't have active angina or active ischemia, the newer guidelines suggest that perhaps they don't need to be on aspirin long time. So we can really take patients that don't need to be on aspirin and stop it. The second part we can do is better manage our warfarin. These were patients that were aggressively managed, but the more frequent we check warfarin, the better education to patients regarding diet, drug interaction, and compliance. We can improve time spent in a normal range and not over anticoagulated. In the third area, we have newer agents that may replace warfarin that perhaps are more steady in the blood, and they tend not to be over or under anticoagulation. Perhaps these agents can lower risk of dementia. That we don't know yet. We want to pursue it in a prospective trial, but it really tells us that that's a possibility, or suggests that's a possibility we need to research. You know, these are important findings in the links between atrial fibrillation and dementia, but at the same time, the links we're finding are things that we can intervene upon. These are things that are related to our approach as clinicians to a patient. like over anticoagulation, we can do something about that. We can, and so we'd hope that we can reduce dementia and atrial fibrillation. I think it also speaks to one of the problems we have in managing atrial fibrillation patients, and that is we see them, we assess the risk of bleed in stroke at a point early in the disease process, and we start a therapy. And often that therapy is not revisited or checked as the patient ages. And as the patient ages, they gain new risks for both bleeding and stroke. And so I think we need to be much more dynamic as physicians with our patients, continually assessing the benefit and risk with these drugs, and perhaps scaling back those that aren't needed, because these trials tell us that just one medicine over time may have some benefits early on, but expose the patient to risks at the same time that we previously weren't considering.